Hi, everybody. Can you guys hear us? Somebody wants to put it in the chat box if you could hear.
Yes, we can.
Wonderful, thank you. Well, we were going to do some clinical updates on COVID-19, and we have some time at the end for questions. We also had some questions submitted, so we'll go over them as well.
Let's see.
Hey, Nikki, on Paula Callahan, we're waiting on her TB titer, or whatever you guys call it, to get back so we can give her a treatment. Could you?
All right, great.
Yeah.
Now, all right, great. So I wanted to start with some interesting historical information. And so there's this this quote, and this is was thought to be one of the world leaders in ID from 1978. And he said, "Even with my great personal loyalty to infectious disease, I cannot conceive of the need of 309 more graduating trainees in infectious disease unless they spend their time culturing each other." And I really like this. This is actually in 1978 when one of my mentors completed his infectious disease fellowship, and it really is worrisome to say that, you know, complete your fellowship and have someone say that you don't need any more ID doctors. And as late as 1985, he was still saying this, and he was saying the millennium when fellows start culturing each other is almost here. And you know, this, and Dr. Fossey, he's quite famous now. I don't have to explain who he is. He's the director of infectious disease and NIH, and he said the belief that infectious disease had been conquered was widespread in the 60s and 70s. And so people thought that we have penicillin, we have a couple antibiotics, anybody can take care of infections now.
Yeah, I think this pandemic has shown how important infectious disease, antimicrobial stewardship, and infection prevention plays a role in keeping everybody safe.
And so looking at how the cases are going right now, and so in the United States, this is, you know, the cases are somewhat leveling off in the United States. And if we were to look at it state by state, California, the cases are decreasing. And if we were to continue to look, so Wisconsin, the cases are actually increasing and going up quite quickly in Wisconsin. In United Kingdom, the cases were high, they came down, and then they're now going up again. And so Europe, it's they're having quite a few cases now.
They did a good job controlling the cases, but what happened is a lot of them eased some of the restrictions, and they started going to vacation and easing restrictions. Now in Europe, there's a number of cases that are coming about in UK, in you know, Spain, Italy, so they're all bouncing back with the number of cases.
Right, and in just a few cases, you know, if you have such if you have exponential growth, just a few cases can quickly go up, you know, and be quite a few cases, and so that's the worry. So if there are just a few cases, the worry is that it's going to quickly increase and get out of control. And so just a few cases can be pretty alarming. And the United States, you know, this is actually a couple weeks, I took this picture. Now we're actually past 200,000. So
Yes.
there are more than this now. You know, the United States is very high for deaths. But if you look at it, mortality, deaths per 100,000 population, Peru is actually the highest mortality. And part of that was that they were having trouble filling just oxygen tanks in some areas. And so in resource-limited countries, they have quite a few issues. I also wanted to include this. This is the CDC website, from the CDC website, and this is a graph of total weekly deaths of all causes over the past 3 years in the United States. Let's see, and so, and with all causes, you know, you can see that there are some peaks here. There's a peak back here from the bad influenza season that we had, and then there's a peak over here from COVID. Let's see. Yeah, and then the peak from COVID, and you can see that. So they have this is kind of the expected number of deaths, and when it goes higher than that, they highlight here with these.
We can't hear you guys now. Your show's muted.
Yeah, how do we get the right? There. So, and you can see this kind of yellow line is the expected number of deaths, and when it goes higher than that, so this is from the bad influenza season that we had, and then over here these are from the COVID deaths.
And I know there's some controversies about like only 6% were due to COVID mortality, but as we all know, when you have death certificates and stuff, most of the time, if you have other comorbidities, ARDS and things like that, we list those first. So as you could see in here, definitely during this time period, overall, our mortality rates have gone up.
Right, and looking at death certificates is notoriously poor. I mean, when they do research, it's not a great way to attribute what the death was from. And here, this was actually came out quite a while ago. This was actually way back, from May, and so this seems like a lifetime ago. And so this, when this was looking at it, it was looking at reported COVID deaths and then excess deaths other than reported as COVID deaths. And so there are probably quite a lot more than actually being reported. When people have infections, it's known that your risk of MI and stroke goes up. And so,
I like that you're saying that, because we know even with influenza, within the first 30 days, you could have stroke, you could have heart attack, and I think you're seeing some of that with COVID infection as well.
Yes, and just with zoster, and when people get shingles, the risk of stroke and heart attacks goes up for the next about 6 months. So, and we see people in the hospital where they come to the hospital with a heart attack, and then on day 2 or 3 we may get consulted for a cellulitis, and they're so worried about their heroic measures and the MI that they may not have done a complete physical exam, or and the patient will say, oh, I've had this cellulitis on my foot that for longer, and they didn't notice it. And so having an infection can put people in a high inflammatory state and risk of other issues. And so that's what this is looking at. So excess deaths. So there's an excess deaths that's not being attributed to COVID.
And another interesting study was it was published in JAMA, where they even mild coronavirus infection, COVID-19 infection, they did cardiac MRI of your heart and EKGs, where they found like even with mild infection and healthy people had cardiac inflammation. So imagine if you have severe infection, how much higher risk they are for heart attacks and other bad outcomes.
And this website's pretty good. You can actually look at it. The past one, the previous slide was the United States, and then this slide is in Nebraska. You can look at it state by state. And so we're going to start by talking about coronavirus reinfection. And so the question, and this is a question that we get frequently, can you get reinfected with COVID? Or once I get COVID, do I have to keep worrying, or can I relax? And there were some cases of reinfection reported in Hong Kong and Europe. And these cases, the patients were, after they've had it the first time, when they got it, when they were reporting it a second time, they didn't get it as bad. Although there was a case, and this is from August 27th, and this is genomic evidence for a case reinfection. And this patient was in Nevada, and he was a 25-year-old that had COVID-19 mid-April, and he had headache, cough, sore throat, all the usual things that you'd expect. And then his symptoms resolved within 10 days. End of May, he got sick again. And the second time he got sick, he was hospitalized and required oxygen. And so they were making a big deal out of this, saying that because he required oxygen, he had it worse the second time. And this is 48 days after he tested positive the first time. and then the genomes were significantly different, suggesting he was infected twice with essentially two different versions.
Two different strains of the virus. Thankfully, we don't see this a lot, and currently CDC says it, to have reinfection, it should at least be 3 months past the first infection. So that's what a lot of us are following. But cases like this occasionally can happen, and I think that's why it becomes even more important, even if you have had COVID-19 infection, to continue to wear your mask and social distance and hand hygiene.
Yes, and this and then so it looks like it's possible about except the question that public health people would say is, but how relevant is this to everybody? If there's an outlier, or if there's something that happens so infrequently, how relevant is it to everybody? We should really be focusing on the masses and the mass majority of people, and so it looks like it's possible, although. Is this something to worry about?
Yeah. I'm not too worried about this, but at the same time, like when you look at the cases, it's usually in like 19 to 39-year-olds are the most highest number of cases. And I think like right now, when a lot of the young people are getting infected, I think there's going to become this like I'm immune kind of, thinking I got the infection, I'm fine now. But it's going to be so important, even if you have the infection, to continue to wear the mask and hand hygiene and glove and physical distance until we get a vaccine.
And so the COVID-19, the spectrum of disease. So you have asymptomatic, or they'll call it, or pre-symptomatic, where they don't have any symptoms. But the majority of people that do have symptoms have mild symptoms. It's very mild illness. You have some people with moderate, and then severe and critical illness. And you can see how the differentiation is whether they're requiring oxygen or not, but the majority of people do just fine, as we know. And then as far as the timeline, because, and this is important when you're thinking about patients that are coming in with exposures, or when they say I was around somebody else, and also when you're taking care of somebody, what kind of, what you can kind of tell them to expect, or what might happen. And so with this, you can see that the days from infection to onset of symptoms, there are a number of days, and then you have onset of symptoms, and then the patients have fever, cough, fatigue, anorexia, myalgias, diarrhea, and then around day 7 or so, they may have some dyspnea in 40% of symptomatic patients. And then if they're going to get sick, they usually get sick about day 10. And so I think this is important, because when we're seeing patients and they come in and you can kind of count how many days since the onset of symptoms, if they're already not doing well at about day 4 or so, or 3, then you might have kind of a heightened awareness and a clinical suspicion that, especially if it's in a patient in a high-risk group, that they may be worsening at about day 7 or so. And so this worsening and kind of this lag is also what makes this so bad, is that people will say, they'll at the start of it, they'll say, well, I'm not that bad. I can still go to work, or I can still go to the picnic or the party or whatever.
They should not.
So they shouldn't, right?
Yeah.
So they shouldn't. This kind of slow onset is part of the problem, where they're not feeling too bad. In other infectious diseases where they have, like, it just hits them and they have chills and a fever, and all of a sudden, it's not the same as something that comes on slowly and they don't feel too bad, and they're able to go and still hang out with people. And so when you're thinking about the time course, also different approaches may be needed for different stages of the disease. So when you look at this here, we have disease severity and time. So at first, while it's incubating and you're having symptomatic infection starts, you probably need to something that if you're going to give them something, something that will fight the virus, and then later on in the disease, as it progresses severe and the patient gets critical, you may want something that will fight the host immune response. This kind of overreaction of the host immune system.
Cytokine, inflammatory markers. I like this graph a lot because it kind of shows like, we know now, like when you have moderate disease, once you start requiring oxygen to give steroids, that help with dexamethasone, that really helps. Steroids, what it basically does is kind of hinders the host immune system, from releasing all those inflammatory markers. So kind of nice to be able to see that, earlier the viral response, but then you want to kind of hit with steroids earlier so you don't start releasing all those cytokines so that you have a bad outcome.
Yes, exactly. And when we think of like sepsis or septic shock, it's the same kind of, it's the patient's overreaction of their immune system causing end organ damage that you want to kind of dampen and kind of calm their immune system. And I think it's kind of funny when, in the public, when the media talks about, the issues with an overreaction of a patient's immune system, there have been some people that have said, well, maybe I don't want a great immune system, right? They'll say, well, maybe I don't want to help my immune system because if it's the overreaction of the immune system. And I think that's kind of a funny reaction to it, right?
And I do think like they're looking into some of that studies, like why, for example, HIV patients, if they're on antivirals and also their immune system is not the best, it looks like they did actually better, but it's anecdotal and more studies to come out.
Right, it's all kind of theoretical.
Yes,
right?
exactly.
I just like the idea of, well, maybe I don't want a great immune system if that's the problem. And so when we're thinking about therapeutics and therapeutic targets, so early on, you may be talking about antivirals and antibodies. And then as you go, it goes into immune modulators and kind of immune system inhibitors. And so the target and kind of the what you need to be fighting kind of changes as the time progresses within the time course.
And I know like when all this stuff started, we were using interleukin-6 inhibitor Actemra, but there's been more studies now. It hasn't shown benefit, so that's kind of falling out of favor. But that idea with Actemra, for example, IL-6 blockers, was it was going to prevent the inflammatory cytokine release, but steroids does the same thing. So that's why, a study shows steroids help. So I think we have that in place of Actemra now.
And so, and part of showing this time course, in a minute we'll be talking about plasma and kind of the relationship of time of when they get plasma, how they do, and also, like you said, steroids and immune modulators. And so it's not only what is given, but also when in the time course, when would it best help the patient. And so here are some of the candidate agents for investigation. So they had, and this is kind of from the start, all of the things that they were kind of throwing out there: antivirals, host target immunomodulators, and then neutralizing antibodies. And we're going to have a few of these corona paradoxes in here. So what is a corona paradox? It's to make sense of something that doesn't make sense and for which there are no ultimate answers. So I think this is kind of funny because, there are a lot of things that as kind of this pandemic plays out, that people will say that you have to stop and think yourself. There's a lot of confusion and things when this first starts and a lot of worry. And politicians have said that we need to stay physically apart in order to stay together for solidarity. And then in Switzerland, the Minister of Health said we must act quickly as possible, but as slowly as necessary. And so I like these kind of things that come out and make you kind of stop and wonder what's going on in the world, right? And so this was actually, again, early in the course. This was in April 2020. But I like this picture because this is kind of, a good kind of way to look at it, where you can see all of the things that are being studied. And so here they have, when there's a line between two things, so remdesivir goes to standard of care, And there were 8 studies right off the bat looking at, and everything's comparing itself to standard of care or to something else. And then these ones that are going kind of in a circle, these are observational studies. And so trying to, make sense, everyone's trying to make sense of all of these studies that when this first occurred, and this was in April, so this is when things first started. And then so since then, this has only gotten more complex, but it just, trying to do everything we can once all of this stuff hits.
I know we get a lot of questions still about hydroxychloroquine and azithromycin. So this study, kind of multiple studies have shown that it doesn't work.
Right, and so we just want to essentially show this again, that hydroxychloroquine isn't something that we want to be giving to the patients. That in some studies it showed that it didn't help, and then some it looked like it was causing harm.
Yes.
And so we just wanted to, as we go through things, just show this again, that hydroxychloroquine isn't something that we were giving.
Yeah, it's not a standard of care anymore.
And then to randomized controlled trials, there were post-exposure prophylaxis, and it was looked at in the recovery trials. And so when these studies first started, there weren't enough tests, and they were having to go off of symptoms, and they weren't able to continue with the tests and everything. But really, the hydroxychloroquine, as again, it didn't show a benefit, and it wasn't. So it's not something that we're using now. As far as remdesivir, it's a nucleotide prodrug, inhibits viral RNA polymerase, and it's a chain terminator. And this was looking at mortality at 14 days, and it was clearest benefit of people were on oxygen but not yet intubated.
And also, they have looked at studies. Do you need 5 days versus 10 days? And 5 days are appropriate. So you don't need to do the longer duration as well.
Right, and so that was in people that were not yet intubated,
Yeah.
right? So if they're intubated, then consider 10 days. We would do 10 days, but 5 days.
Even if you're intubated, there are still some coming out like 5 days is enough.
Okay. Yeah.
So what we're for the majority of the time doing is just 5 days. There's a lot of concern now with remdesivir. It's no longer a free drug, and also needs to be paid cost to the patient and the hospitals as well. So a lot of what's coming out is 5 days is appropriate, intubated, not intubated.
And really what this study showed was that recovery was more rapid. So it showed recovery was more rapid, and mortality looked like it was improved, although it was not significant. So, but perhaps if you had more patients or continued this out, it would have shown significance. And then dexamethasone. So, whenever, there are really with anything, everyone always wonders, would steroids work? Usually with viral pneumonias, it's kind of controversial to talk about steroids and see if steroids will work. But this was looking at dexamethasone, and it was looking at dexamethasone versus the usual care and mortality. And so it was showing a difference. It was showing that, and the biggest difference was, patients that were on oxygen or intubated, but for patients that are not on oxygen, it didn't show a benefit. And you can see, so this includes one here. So it wasn't really showing a benefit here.
So if you had any oxygen, or if you're in the intubated, ECMO was beneficial, but not for non-intubated, non-oxygen patients. But what I'm seeing is a lot of people are using steroids even on the non-oxygen patient, and there's no data on that. So, but I have seen some of that as well.
Yeah, so if they're not requiring oxygen, then we wouldn't give them steroids.
Yes.
And actually, patients that there wasn't a benefit to these patients that weren't on oxygen, and there may have been a harm.
Mm-hmm.
And so I think in this study they were looking at, it was up to the treating clinician to decide if there would be a harm. And so some patients, there was a harm, or they, uh, and that's really the concern anytime you give steroids, is to do no harm. And so here you can see that with the dexamethasone is better on this side, and usual care is on this side. So no oxygen received. You can see it's crossing 1 here, and so this is didn't show a benefit, but it was better for patients that were intubated or on oxygen. And it was showing it for all patients, but when they broke it out and looked at it by oxygen requirements, that's when you saw the difference there. And this was just showing the FDA broadens the emergency use of remdesivir. And so we've had, this emergency use for remdesivir, and then also they had the same type of thing for plasma.
Yeah, and when they broaden the use of remdesivir, now they're saying it's okay to give it to anybody that is in the hospital setting. But, the drug is still very limited. And also now there's cost is a factor as well. So I think in each healthcare facility, we still have to have a triage and who gets remdesivir. And, currently some of the practices are, if you are not on oxygen and doing okay, I don't think those patients need remdesivir at that time. So, some people use 2 liters or less. You don't need remdesivir. But it depends on the supply where you guys are, and if you have enough to give it to everybody, or do you need to have a little bit more criteria so you could use your resources, wisely.
And so we have another one of these paradoxes. So this, and this is somewhat theoretical, but I find it interesting. They talk about a vulnerability paradox, where prior experiences to crisis and disturbances, and coupled with trial and error process of learning to deal with them, makes a society more resilient, whereas high levels of economic welfare and lack of recent crisis leaves some societies less prepared. So if the society is doing very well, they don't take warning when things are starting to look bad. They'll kind of be more relaxed and not thinking that they need to prepare. And I find this kind of interesting. And this was within Europe, the Greek handling COVID-19 appeared to be more successful, and they were kind of hypothesizing that maybe that Greece is a country that they've had so many issues that when they see another one coming upon them, that they kind of say, well, we need to get on top of this immediately. Whereas other places didn't do so well. And it's kind of an interesting concept. And also part of it had to do with trust in their government, because if you trust the government that's giving you their answers, and you trust what they're saying, then if you don't have a high level of trust, if the government says it's going to be okay, you still may say, or even within your family or local communities, that you need to prepare. Yeah. And so if the government says it's not going to be that bad, if you trust the government, you may not prepare. Whereas if you don't trust the government, you may say, well, I don't believe them. We still need to take all the measures that we can to protect ourselves.
I think this is when public health and coordination of public health and working nationally is so important, because we all still struggling, and but hopefully we'll get to a better place.
Right. Yeah, I think the best is for governments to be honest and to trust the government, so you can know what to expect. And here so when we're talking about plasma, one of the things is the questions will be, is plasma safe, right? And so this was looking at safety indicators of plasma, and they found there were some cases of transfusion-associated circulatory overload, which is also TACO is for short, which is my favorite. So you'd say, does the patient have TACO? And then the other one is TRALI, transfusion-related acute lung injury. And both of them you'd kind of manifest as shortness of breath to start with. But there were some cases, but they concluded that it was still safe, that the mortality rate was not excessive, and plasma, first they kind of look at safety, and then does it help? So yes, it was safe enough. And then the effect of plasma on mortality among hospitalized patients, a 3-month experience. And this plasma was tested. They kind of looked at a couple things to evaluate the concentration of antibody. So all the plasma that was given to the patients, they also looked at uh, what was the concentration of the plasma that the patient received. And then they also looked, and then the other thing they looked at was how did the patients do? They looked at 7-day mortality, 30-day mortality, and how did they do with relation to the time frame? So 0 to 3 days, or did they get the plasma after 4 days? So they looked at the concentration and then the time relationship. And so this this was the initial 3-month experience, and the 35,000 people, and these are all types of patients. So they didn't have a control group for this. That this was an observational study where they wanted to do an observational study for a couple of reasons. One, to get as many patients as possible to have the opportunity to get plasma. So they didn't want to decide who gets it and who doesn't get it in the setting of a pandemic response. And there are also some ethical questions here if they were to design a study where they decide where one city gets it or one hospital in this population gets it and another city doesn't get it. And then also as the pandemic was moving across the country, they didn't want to try and guess where it was going to hit next and then and not help people if that not have the possibility of helping people. So what did, oh, sorry.
And it's nice to see that the 30-day mortality was lower for the plasma.
Yes, it was lower, and the it was also lower within so the 3 days it was the lowest, and if they got it after 4 days, it wasn't as low. And so plasma has been used in the past, and even before we had antibiotics, they were doing giving people plasma, and so plasma is essentially person's antibodies, but it's not straining out for just the one antibody. It's kind of a mix of all the antibodies that the person has.
So if you have influenza at the same time, you're getting antibodies to the influenza too. So just all the IgG.
Yeah, so it's not, ideally you would just pick out the one antibody that you want. And so it's kind of what you're getting. You're not so sure that you're getting a high concentration or a low concentration, but there are antibodies from people that have gotten COVID and overcome it. And so hopefully they have a high amount of antibodies for COVID. And importantly, the gradient of mortality was seen in the relationship to the IgG antibody levels. So 7-day mortality, if they got a high concentration, it was 8.9, medium concentration was 11.6, and a low concentration of antibodies was 13%.
That's pretty impressive, right? Like if you had really high antibodies to COVID-19, you did better, but it's so hard, nobody's measuring that in the plasma. So do you think they will do that in the future to measure the level of IgG?
Well, I hope so. I hope they get, essentially, I think you want a monoclonal antibody and just, high concentrations of the specific antibody that you want. And instead of just kind of relying on, hopefully I have good the person I'm getting the plasma from had high antibodies. And this is another way of looking at the same thing. So this is the 7-day adjusted mortality. And then down here with the different colors, this is the concentration of the plasma. So this is high concentration, medium concentration, and low concentration. And so the 7-day adjusted mortality, so the people that got higher concentrations, the mortality was lower. And when you took this and then you kind of, and this over here, the 7-day adjusted mortality, these are all comers. If you look here on the right, if you divide it out into those that got the plasma in less than 3 days versus more than 4 days or more, so you can see that the people that had the lowest mortality had a high concentration and got it early. And so the plasma, the highest benefit is probably if they have a high concentration and they get it very quickly. And early when they started doing this study, early in the study, most of the patients were getting it after 4 days, and that was just trying to coordinate the study and and organization and get it to people. And then later, people were starting to get it earlier, less than 3 days. And this is 7-day adjusted mortality. If we were to look at 30-day adjusted mortality, there are more things that come into play, and it doesn't have as large as a splay here. We don't see a bigger difference, or as big a difference as the patients that got high concentrations and got it early. So one of the questions that we get kind of frequently would be, is there a benefit in giving plasma again? And so really this is just looking at patients that got plasma early in the course. And so if you were to look at this, it wouldn't really make as much sense to give plasma a second time, maybe 20 days or 15 days. Some of the patients stay intubated in the ICU for a long time, but I would say the biggest benefit is going to be to give it early.
Because that's when your virus is replicating. So if you're giving plasma, is basically antibodies to the virus from someone else. So those antibodies fight the virus to stop the replication. But some of those patients that are sick and 20 days in, now it's not the viral replication as much as the virus has done so much damage to the lungs. So I don't see a benefit in giving plasma at that time.
Right, exactly. It's like the slides we looked at earlier with the time course here. Yeah, because it's going to be the host response or ARDS later on. And so the conclusion was the relationship between mortality and time to plasma transfusion antibody levels provides a signature that is consistent with efficacy for use of plasma. And so they didn't directly out and say yes, because this wasn't a randomized controlled trial. This was an observational study. And so if we're looking at it, we'll say, yes, that's great, but it's not the best evidence. And so because we want randomized controlled trials, this is the NIH recommendations and guidelines. And so what did they say? They said there's still insufficient data to recommend it. So even though that looks like it's very strong, it's still an observational study and not a randomized controlled trial.
And I also like this website and the NIH guidelines because, if anybody needs more information, it breaks it down really nicely. They have information on steroids, they have information on critically ill patients, they have information on vitamin D, vitamin C, vitamin zinc. So it's a really good website and a link to go look at when you guys have questions.
Yeah, this website I think is great. And NIH is great.
Yeah.
A great resource, and so so they didn't recommend giving it, but if I were sick, I would want a lot of plasma. I would want a couple, give me a couple infusions of plasma really early.
Early, yes, as long as it's early in the disease,
as long as it's early.
3 days.
Yes, exactly, right. Yeah. So some of the head people said even in a pandemic, the best evidence isn't observational studies, and we're not going to change our standards, even a pandemic. So, and then we'll talk a little bit about droplet versus aerosol.
Yeah, we have 5 minutes left, so I want to get into questions, but I'll just, this is just a nice diagram to show how far, infect a person with large droplets versus, TB droplets, how far they go. And here's a nice diagram on droplets, how they spread when you don't have a mask versus when both of us have a mask I think when both people have a mask on, the chances of the uninfected person getting infection is about 1.5 times as high. But if the infected person doesn't have a mask and the other person has a mask, there's still 5% chance of getting an infection. So it's really important, cannot emphasize the importance of wearing a mask and N95 when you're doing aerosolized procedures. And
then this is just saying that this is one more paradox is that complex problems usually have complex solutions, but this is a complex problem that has a simple solution, and that's wearing a mask and practicing social distancing.
Yes.
And then we have some questions here.
So the questions that were submitted is there any difference between PO and IV dexamethasone? There isn't. So, what we have for our patients is when they could take oral dexamethasone, they could take oral dexamethasone as long as there's no absorption concern or they're not having ileus. So oral and IV pretty much the same. So if they're an IV and then they're now taking oral and they're doing better, you could switch it to oral. Next question is there any benefit to zinc, vitamin C, vitamin D? NIH, not a lot of info on zinc actually. There's, some of the studies from past viruses that zinc prevents viral replication, but there's not a lot of studies when it comes to COVID. But vitamin C and vitamin D, we know it helps with your immune system, boosting your immune system. Vitamin C also, NIH says not really a lot of evidence to vitamin D, but there's more studies coming out about vitamin D. They're looking at ICU patients with COVID, and a lot of patients in the ICU are having low vitamin D level compared to other patients. So there might be a role. Still, NIH has not recommended it, but to be honest, since the COVID pandemic started, I take a multivitamin and I take a vitamin D. So I think there's no harm, but at the same time, there's no solid evidence to say yes or no.
Right, and I think Dr. Fossey takes vitamin C and
Vitamin D.
And
yes.
I think my feeling on this is it may help, but it won't hurt.
Yes.
And so if you want to take it, that's fine.
But I just don't know about zinc. So that yes. Yeah. But C and D, yes, won't hurt. Remdesivir duration, let's say you start somebody and on day 3, they're looking fantastic and they're ready to be discharged. Do you need to keep them for 2 more days to finish your 5 days of therapy? No. If they're doing well, you could stop at day 3 and they can't be discharged. That is kind of the line of thought now. So 5 days is appropriate. And if the patient is doing fantastic on room air, they're doing well, and on day 3, they're ready to go home, you could give that dose and they could go home. You don't need to keep them for 2 more days to give the remdesivir. Next question we had was Tamiflu. Does it cover COVID-19? Tamiflu does not have activity against COVID-19. Tamiflu, however, has activity towards influenza A and B. So, during this flu season, if you're worried about influenza, Tamiflu, Ostelmavir, you could give it to the patients that need it, high-risk patients, if you're hospitalized, but unfortunately, it does not have any activity against COVID-19. Patients with COVID-19, when can they get the flu vaccine? So if you recently had an infection, ideally after 10 days of, the infection period has settled down, you probably get the influenza vaccine. And another thing to remember is most of the influenza vaccine are not live vaccine unless you're getting intranasal. So I don't see an issue with getting an influenza shot after 10 days of having COVID-19 infection. Remdesivir side effects. The big side effects to watch out for are kidney failure. So you could use remdesivir as long as your GFR is greater than 30. And you could also use remdesivir as long as your ALT, not your AST, your ALT is less than 3, upper limit of 5 times the upper limit of normal for your labs in your hospital. And those are the big ones, kidney and liver. And the other things some patients experience are mild fever, vomiting, nausea. So some other things to keep in mind. Another question was anticoagulation. CHEST guidelines updated anticoagulation, so that's a good resource. Also, NIH guidelines also have some information about anticoagulation. Current line of thought is people should have, if they're admitted to the hospital, they should have DVT prophylaxis, like we always do. But only people that should get full anticoagulation are if you're suspecting a DVT, actual clot, or PE, or other type of clotting issues. Otherwise, they're just recommending for the others just to do prophylactic dosing, not treatment dosing. We have learned a lot, when it first started, a lot of people were getting treatment dose and anticoagulation, but now we're kind of going seeing what we have learned. Influenza, treat with Tamiflu this year. Obtain influenza vaccine earlier the better, because you want to avoid the twindemic. I'm sure you guys have heard that phrasing. So trying to get influenza vaccine as soon as possible, so for the next 6 months you have the antibodies ready and producing antibodies. And the last question is, if somebody is getting admitted to the hospital, strongly consider during influenza season, you're going to have a hard time figuring out if they have influenza or COVID-19. So if you're getting admitted, consider doing a PCR testing for influenza, because a lot of times when you do the rapid influenza antigen, you're going to get a lot of false negative, even though they have the infection. So what we're working towards is during influenza season, if somebody's sick enough to get admitted to the hospital, we need to have accurate information. So we're, hopeful PCR for influenza and PCR for COVID-19. And we also get a lot of questions about co-infection with influenza and COVID-19. What do I do if somebody has influenza? Do they still have COVID-19? We don't know that data yet. I'm not sure what is going to come out this, influenza season, COVID plus COVID. So I think it's going to be really important to keep both in mind. There might be chances people might have co-infection.
Right, and so and the concern about co-infections, so if the patient, all you've really found is COVID, stopping the antibiotics would be a good plan. Yep.
And then, I also think some patients have community-acquired pneumonia, hospital-acquired pneumonia. Yep. In those cases, I think it's really going to be important to get sputum culture, get some more data. And there are some, for patients who have been with COVID-19 for a prolonged period of time in the hospital, they're getting hospital-acquired pneumonia with MRSA and Pseudomonas. So I think it's key to be able to get more culture data when you're using antimicrobials.
Okay, great. So if anyone has any questions, you can ask us or type them in the chat box.
Those were the questions we received earlier, but if you have other questions, we're happy to answer. Well, thank you for joining us. And please let us know what will help for next webinar.
Yes, if you have any suggestions for future webinars, please send them to us and we'll cover any topics that you like. So thank you again, everybody.
Thank you.
Thank you.